Hamstring injuries are a relatively common finding, and they are a common problem for the rehabilitation specialist. These can be insertional hamstring injuries or mid-belly hamstring injuries. The mechanism of injury is usually sudden eccentric loading of the muscles. For example, the hurdler, as he's reaching over the hurdle itself, sprinting, so the lead leg as it reaches out to take the next step, as the hip is flexing and the knee is extending, that puts a huge load on a huge tensile load on the hamstring muscles themselves, and requires an element of eccentric control. Factors that predispose individuals include tight hamstrings, imbalances between the quadriceps and the hamstrings. So if the quadriceps are too strong for the hamstrings, then as the knee is extended forcibly by the quadriceps, the hamstrings are unable to control this movement of extension. Poor eccentric control of the hamstrings, so individuals that have trained their hamstrings but only train them concentrically, and also poor coordination of the hamstrings muscles, in particular synchronous firing of the two heads of biceps femoris. Fatigue also contributes to individuals individuals developing hamstring tears, as the hamstring muscles may fatigue quicker than the quadriceps. Here's a diagram of a hamstring injury. You can see it's fairly extensive bruising. This is typical of an individual who has torn their hamstrings, because the muscle is so vascular, invariably bleeds, and this comes up to the surface. The individual may describe pain on resisted knee flexion and or hip extension, and there will be a palpable tender spot. In severe injuries, in large injuries, there may be a palpable tear that can be felt by the examining clinician. Hamstrings respond very well to local conservative treatment, but the long-term focus must be the complete re-education of the hamstrings, including eccentric control, quick movements, and proprioceptive activity. Often, one of the causes of recurrent hamstring injuries is inadequate rehabilitation. If there are any predisposing factors, for example, tightness of pelvic movement, imbalances, stiffness of the lumbar spine, this has to be addressed as well, as this often leads to a recurrence of hamstring tears. One of the common complications associated with hamstring injuries is involvement of the sciatic nerve, which may lead to adherence of the sciatic nerve to the healing hamstrings. This can be differentiated quite easily by the inclusion of dorsiflexion as the hamstring is put on a stretch. Quadriceps tears are also relatively common, and these may be as a result of direct trauma, for example the dead leg, or as a result of sudden loading or stretching, for example rectus femoris being torn during a kicking action. Again, these present very similarly to hamstring tears in that there may be extensive bruising, there will be local swelling and pain, and there may or may not be a palpable tear. Loading of the quadriceps will lead to severe impairment of function, so they will find that they'll struggle to go up and down stairs, sitting to standing. And again, these respond quite well to local management, local treatment. Once again, rehabilitation must be complete before allowing return to full activity, as the incidence of recurrence of quadriceps tears is relatively common. There are three main bursas around the hip and pelvis. There's the iliopsoas bursa, the trochanteric bursa, and the ischial bursa, and any one of these can become irritated. The iliopsoas bursa is found between the anterior hip and the iliopsoas muscle itself. Its function is to prevent friction between the iliopsoas muscle and tendon against the anterior pelvic rim or the anterior hip. And iliopsoas bursitis is commonly as a result of overuse. The pain is often dull and diffuse over the anterior aspect of the hip, and the individual will describe symptoms when you resist hip flexion from an extended position, or flexing the hip into a compressed position. So flexion adduction of the hip in particular often leads to a pinching or a pressure pain in the anterior aspect of the hip. Again, this is managed fairly well with relative rest, avoiding the activities that stir it up, and stretching the iliopsoas complex. If iliopsoas bursitis does not resolve with conservative management, an injection of hydrocortisone and lignocaine invariably calms things down. Trochanteric bursitis is an irritation of the trochanteric bursa, which is found over the apex of the greater trochanter and the gluteal muscles. It separates the gluteus medius and minimus from the apex of the greater trochanter, and it's often as a result of repetitive loading and moving during weight-bearing situations. Irritation of the tendon and the ITB complex can also ensue, and it's found fairly commonly in long-distance runners or people who do sustained loaded activities. Tight ITB will predispose an individual to a trochanteric bursitis, and poor running biomechanics may also contribute to the whole problem. In trochanteric bursitis, pain usually develops over a period of time, and it's usually found on the weight-bearing phase of the gait cycle and on tensioning the abductor, so for example crossing legs or climbing stairs or getting in and out of a car. Clinically, when we resist abduction or passively flex, adduct and immediately rotate the hip joint, we usually get positive signs. Ober's test is usually positive, indicating tightness of the iliotibial tract. Pain is usually fairly well localized, but referral along the lateral aspect of the thigh is not unusual. There is usually an acutely tender spot on the apex of the greater trochanter on the affected side, which often leads to the individual saying they don't like lying on that side. Management involves very much like iliopsoas bursitis, relative rest and conservative treatment to reduce the inflammation, but it's important that tight structures are mobilized. So iliotibial band release often works very well. Trigger pointing around the gluteal region often helps prevent recurrence. And finally, ischial bursitis. This is known as Weaver's bottom. It's called Weaver's bottom because the ischial bursa separates the ischial tuberosity from surrounding structures. And in the old days, weavers, where they used to sit on their backsides for long periods of time on hard stone, cold floors, they would get irritation of the ischial bursa. It's often associated with sustained loading during sitting, and it may or may not be sparked off by a sudden impact injury, so an individual falling back and landing directly onto their backside. It's aggravated often by tight hamstrings and excessive hill training in particular, so running uphill creates tension and compression of the ischial bursa, and there's often pain when you palpate the ischial tuberosity directly. It's occasionally mistaken as a hamstring pull, but may be differentiated by the absence of pain on resisted knee flexion. There's a handful of syndromes associated with the hip joint. For example, snapping hip syndrome, piriformis syndrome, and iliotibial band friction syndrome. Snapping hip syndrome is a common condition that's associated with dancers, especially dancers involved with lots of forced adduction in a loaded position. It's often made worse when the actual limb is held in an adducted position. The cause is unclear, but it's possibly associated with tight gluteal and ITB muscles, and there's a distinct snapping over the greater trochanter. It's often relatively asymptomatic, but the patient can often stand and reproduce the snapping sensation. On assessment of the individual, you may find that a single leg stance leads to inadequate hip abductors, and the patient may present with a positive Trendelenburg sign. If it's painful, local treatment to reduce the pain and inflammation works quite well, but the most important component is stretching tight structures and improving the quality of the stabilizing structures. Piriformis syndrome, on the other hand, is as a result leads to sciatic pain, often as a result of tightness or hypertrophy of the piriformis muscle, which can be seen here. The sciatic nerve emerges from the inside of the pelvis through the great sciatic notch, undercover, or sometimes through piriformis itself. And as piriformis hypertrophies or gets tight, it creates pressure on the sciatic nerve. The onset of pain is often gradual, but invariably goes down the back of the leg and leads to a set of neurological symptoms that are often mistaken for nerve root compression. It's aggravated by structures that involve twisting and turning, and rotation of the hip leads to a reproduction of the sciatic pain. Contraction or tensioning piriformis will reproduce symptoms, and piriformis itself is often tender on palpation with identifiable trigger points. Management is often quite successful using trigger point therapy and or stretching or myofascial release of piriformis itself. It's not uncommonly associated with hamstring injuries, as pressure on the sciatic nerve may lead to overactivity of the hamstrings themselves. And finally, iliotibial band friction syndrome, sometimes called runner's knee, because it's most commonly seen in individuals who run long distances. And this occurs as a result of repeated movement in an anteroposterior direction or compression of the iliotibial band over the lateral condyle of the femur. The iliotibial band is separated from the lateral condyle of the femur via a bursa, and it's the bursa that gets irritated, and consequently we get a typical bursal pain, a sharp localized pain on the lateral aspects of the knee, which is aggravated whenever the individual is made to do any sustaining activities. The pain is often very disabling, leading to abstention from their activity. Pain is often on the loading phase of the gait, so when the knee is moving from flexion through to extension during walking and or running. The role of the ITB is to provide stability of the semi-flexed knee, and flexion extension movements of the ITB leads to an AP, an anteroposterior glide of the femur relative to the femur. And there are a number of factors that contribute to the iliotibial band friction syndrome. Some of them may be local symptoms, so local factors, so tightness of the ITB itself. Others may be extrinsic, such as the incorrect running shoes. The symptoms the individual describes there is often a history of prolonged use, and there's often recurrent tensioning and loading of the ITB leads to an irritation. Initially the pain is dull, but invariably it becomes very sharp and localized, and it's aggravated most commonly by downhill running and or cycling. Clinically, we often see abnormal biomechanics and tightness of the ITB. So we get a positive Ober's test. We get local tenderness over the lateral aspects of the knee. And we may also identify certain biomechanical factors like variation in leg length, so an altered leg length discrepancy, or an increase in the Q angle. There may be lower limb biomechanical faults, so the gait mechanics may be altered, and the use of footwear and or orthotics or technical aspects in running may lead to an aggravation of symptoms. The management is to control pain and calm down inflammation and modify activities. Biomechanical correction is an essential component of the ITB friction syndrome, as is improving the mobility and flexibility of the iliotibial tract itself. Stabilization of the proximal muscles, or the gluteal muscles in particular, is often necessary, and return to activity must be gradual.